Perfect. Well, thanks, guys. It's good to see y'all again, even though it's virtual again. I know we'll be happy when some of this, we're allowed to see each other and continue to see each other face to face. And I was hoping to make it this time in person, but unfortunately, I think everybody had the same idea that you guys had, and it has been crazy traversing all across the country, talking and speaking, but you guys are in one of the areas that I love, Colorado, and I'm sorry I couldn't be there in person. But I'm Asbel Montez. I am actually now with a company called Solutions Group. I'm managing partner with my business partner and I with a company called Solutions Group, but still do a lot of work specifically in the ambulance space. Many of you probably knew me when I was, or in the beginnings of this, when I was a senior executive with a company out of Louisiana called Acadian Ambulance Service as well. But now I'm just doing a lot of work across the country and federally and on a lot of state projects, specifically around the reimbursement concept. And right now, of course, there's a lot of scrutiny been given to this, especially with our rising cost. And our reimbursements have not been keeping up, and they're really not keeping up now. So I'm going to be walking you through a few things, and you're going to hear from me between today and tomorrow, I think, on some pertinent issues. And hopefully it's something that you'll be able to write down. Now, remember, you will have access to this. And also we've gotten a little snazzy, and you can actually, if you got your phone ready, you'll be able to download the presentation via QR code as well. But I'm sure Shirley and Kim and the team will also get this out to you by email too as well. And then all this will be available to you as well. So they've asked me to talk on a few different topics, and I'm going to talk around the navigating the complexities of insurance contracting. This has really come to the forefront of the industry, specifically as we are beginning to gear up for either the inclusion of the No Surprises Act, or many are going to be working at the state level on some of those balanced billing provisions. And what does that mean to be an in-network provider? Or are we going to be doing some things statutorily that maybe, even if you're out of network, will kind of simplify this process a bit? And I know this is something that the state of Colorado considered, and it's currently been in a study type environment, waiting on to see what happens at the federal level. And I'll be talking a lot about the No Surprises Act tomorrow, and what we've learned and what we should be expecting over the next 6 to 7 months as we gear up for the advisory committee that's going to be making recommendations as well. So this is going to be a little bit of that. If you're considering insurance contracting, what you should be thinking through. This is new for a lot of you. And if we don't do this right, it could actually hurt us 3 to 5 to 6 years from now as we start working through some of the processes. And that has been pretty eye-opening to me as I've been going and working with a lot of companies, especially over the last 2 years, and some that have actually been negotiating insurance contracts and things like that. And how do we stay competitive, and how do we artfully negotiate? So I'm going to walk you through a 5-step process on what I would consider that you should at least at a minimum consider. That doesn't mean it's an all be all, but it is to give you kind of a guide if you're new into this or you're unsure, you've never done this before, kind of giving you some resources to walk yourself through that piece. And as always, if you've got questions or whatever, I'm sure they'll help facilitate that for me as well. For you that may not know a bit about Solutions Group, go to solutionsgroup.com. It'll tell you a little bit about what we do as well. We are a technology platform, but we also do a lot of reimbursement. So that's about the only plug that I'm going to give for what I'm doing as well. But please check us out as well. Remember, and this is going to become critical, deductibles are resetting. And if you stay with me through some of what I'm talking about, I'm going to tell you why we're really talking through this. If you do not have something in place where you are looking at the deductibles and monitoring it, it's going to become really important for you to do that. But remember, that is coming up January the 1st as well. So let's walk through, and I'm going to really focus on my disclaimer as well. This is not any legal. I am not an attorney. That is Scott, who you probably have heard from as well. But a lot of what we like to tell you we're doing for informational purposes. And because I'm going to be involving insurance contracting, I am really presenting this for informational purposes only for you. If there's something that you question, something that you want advice on, I would strongly suggest that you reach out to your legal, to legal representation if you need somebody to represent you through the process. So I'm going to be just giving you a guide here, and it's really only meant for informational purposes as we walk through this. So first of all, we need to understand why. So ever before you go into this, you need to understand why you're doing it, and you need to weigh that. But I really want you to make sure that you understand the other party. A lot of us that have been negotiating for years on this and how we're successful understand the art of the negotiation. There really is an art to it. And they have business classes on this. You can get your master's degree on this. A lot of this, especially if you're an attorney, a lot of this is something that you will learn through the process as well. But there is a lot of learning that can be done, but also understanding and watching others is what they do. But really understanding the other party is critical to that. It doesn't matter your size. And I've done insurance contracting for very small agencies that usually do 20 to 30 to 40 transports a day or less. And then, of course, very, very large agencies too. And so it really is all about the negotiation and how you negotiate and who is going to fold first. And then I'm going to give you 5 pillars to kind of consider, and then I'll open it up for Q&A. This won't take the full hour, so stay with me here. And I know you're coming back from lunch, it looked like. So some of you guys might start falling asleep from carb overload. So hopefully I won't make it too boring for you through the process. So let's understand the why. The reason why a lot of us are now focusing on this is because of the provisions that happened within the Consolidated Appropriations Act and the No Surprises Act. Tomorrow, I'll go a little bit more in depth for you that are not very aware of everything and kind of break it down as simple as possible. But there are some provisions in there that require what we call a good faith negotiation if you're going to go into a dispute process. And so this is kind of where, how do you establish what we call a good faith effort or a good faith negotiation that's done between both parties, whether it was the provider or whether it was the payer. And so now it's becoming indicative of that. A lot of times as a 911 provider or a governmental provider, maybe you were the only sole source there. It's like, too bad, so sad. When somebody calls 911, this is what they get. I'm not contracting with anyone anymore. Those days are fast diminishing, folks. And so whether you're a governmental provider, you're a private provider, you're a nonprofit, you're a public-private partnership, we really need to begin to understand that probably contracting is going to be, in most parts, there's going to be pockets where there might be some areas where that may not be the case. But for the most part, you're going to begin to see this crop up a lot more with cities. It's very interesting to me that I get more reach out from a lot of city governments now wanting to try to understand how to negotiate with payers and what the process is and how they can maneuver this through their city processes. And if there's some refinement that they may have to do ordinance level to accommodate this. And then what are the best practices with it? So I think we're starting to wake up as an industry that this might become more of a issue for us. And then how do we sit and negotiate? Because a lot of governmental entities, especially, don't really know how to navigate the waters of actually negotiating with something. A lot of times you just put out an RFP, whoever does the best price, you look at the prices and then you choose. Negotiating an insurance contract is probably it's going to be a little different than something like that. The one thing that we'll pay attention to as well is there's a lot of impact that's happening on the state legislation side. So as we work through the federal side of the No Surprises Act, what are some things that could be happening on the state impact side? So when I talk you through what ground ambulance should be considering and looking at or whatever, your state will become really an integral part in what we do. Especially from contracting, because they could implement some stuff that could supersede anything that's done on the federal level. And I'll explain a little bit about more tomorrow, but there are certain associations. So think the NAIC. The NAIC is the National Association of Insurance Commissioners. So this is kind of an association that all the insurance commissioners from every state are a part of, and they will model and look at certain things, and they will talk about things that are happening, and can they put together model legislation. And so NCOIL is the same thing, but it is basically an association for your legislators that are in the insurance component of the legislature. So that association is a little larger than, of course, your Insurance Commissioner Association. Technically, you have 50 of them, but an insurance legislator, you could have hundreds of those depending upon how many in each state or maybe a part of the insurance committee or something like that. They have actually produced model legislation on balance billing, how to mitigate that. They actually came up with model legislation on how to impact air ambulance and what we should do with ground ambulance. And so how is that intertwining with what the feds are doing and then what your state may be looking at as well, if they're looking at models? And how could that impact insurance negotiations if we set payment rates? Or we don't set payment rates? And then what if you need to get in? What if it only covers certain codes and maybe it needs to be non-emergent code? So this is kind of why we're having this discussion on insurance. But first of all, you need to do your research and understand the why. And that's why I'm bringing this out, because it's more than just reaching out to the insurance company, picking up the phone and looking at rates. There's a lot more involved in negotiating with an insurance carrier than just that. But first, you need to understand where everything is, because I can guarantee you the insurance carrier has done their due diligence on some aspects of it. Not all have, and so you can prey on their ignorance on some of it, but then you just need to know where I'm starting from. So when they come forth, you can begin to tease out a little bit about what they might or might not know and who and where my bargaining power is. Now, number two is, of course, the prohibition of balance billing. That is something that's not new to you guys in Colorado. I'm going to leave that alone because we're going to go intense with that over time and ignore this. This looks like that typo did not get updated, but that is not your piece of legislation. As you can tell, I was doing this for actually the state of Texas as well. But there is some provisions that you guys do not have a balance billing provision as it relates to air or ground ambulance at this point in time. I think you started on that from my understanding, but they were able to stall that in your last legislative cycle. So let's talk a little bit about, and understanding let's talk about the other party. So who am I going to be negotiating with? And most of all your negotiations are going to happen right now where I'm strictly focusing on the commercial insurance. I'm leaving Medicare managed care organizations out of here right now and Medicaid, but the same principles will apply. So I'll try to include them through, but most individuals, if they're contracting with carriers, a lot of it applies. But when we start talking about the rate structure, when you're talking about Medicaid managed care and Medicare managed care, a lot of those will follow the fee structure of Medicare or Medicaid, not in all cases, but most of the times they will. But it's usually some of the inclusions of the other contract clauses that you need to pay close attention to when you're doing that. And I'm going to give you some tips regarding that you'll be able to take away with you as well. Now, what I did is, as you understanding what does the state look like, or that I'm going to be looking in. So if I'm contracting with an insurance carrier, I need to understand who I'm dealing with. What's the 80-20 principle? Most of you know I'm always looking at things as the 80-20 rule, because you could have 50 insurance carriers in the state of Colorado. Well, I'm not going to go after all of them. I need to go after the ones that have the most lives. And most of this information is publicly available for you somewhere. Some states, it's really easy to find. In some states, it is hidden somewhere and you got to go here to find it and go somewhere else to find it. In Colorado, I just tried to give you some summation. I didn't pull everything. I just started looking around from what I could do some really quick research on to try to find out what are my top health insurers right now in the state of Colorado. And I was able to find some of this information within your Department of Insurance, as well as I commonly will look to the Commonwealth Fund, which is a great nonprofit aggregator of a lot of state facts, whether it's Medicaid, commercial products, as well as also looking at the Kaiser Family Foundation. Those are two different areas, and I do have those websites that I'm going to recommend to you as you're doing some research. Those are really some really good go-tos that will help you bifurcate and aggregate data to where it makes it into a much more usable, friendly standpoint. So here are some of the areas where you're going to want to look. Most of this is probably very familiar to you already, but kind of begin to understand what type is in my area. You can even go down very granular into each county, into each city, how many insured lives are in that area. And why is that important? Well, an insurance carrier, if they only have 50,000 insureds in your area, may not be as willing to negotiate certain things because the impact to the amount of transports that might cover their lives is minimal. And so they may not even care at this point. Or they're looking at access provisions. Whereas you've got to show value. It's the same argument that's made a lot of times if you're looking to get into mobile integrated health or community paramedicine or some other things where you're trying to show value to the health plan, is you got to understand how many lives are in your covered area. What are you looking at? If I'm going to start the negotiation process, what is that going to do? So really understanding how many of the carriers are in my area, who has the most lives in this area. And so I'm going to target, and usually, guys, it's going to be 3 to 5, max 7 that you're going to really go into to get to your 80-20 principle. But first of all, you need to understand who those, and they are changing by region. So a lot of times it could be different than what you're doing in Colorado Springs, might be different than what you're doing in Denver. And I'm going to get myself in trouble if I start naming too many cities in the state of Colorado. But you get my drift of what I'm walking you through here is understand what those lives are doing. Now, also start understanding the self-insured side of things. What I do know, and this is information that came from the Kaiser Family Foundation that is publicly available right now, and it's from 2020. 2021 data has not been released yet, and it was not uploaded correctly yet. But right now, what we do know is that about 51% of the lives covered in the state of Colorado are what we call self-insured. They're part of self-insured plans. So they're employer-sponsored. They fall under ERISA. And so what happens there is pretty much half of all of your covered lives are not currently covered under any of the state law for ambulance. So even if they would included ambulance in any legislation that they did on the state level, 51% of those lives would not have been covered under those state provisions currently, because ground ambulance is not in the No Surprises Act. So 51% of those lives would not be there. That's just important to note. Because sometimes you're calling, or if you think that you've got something and you're appealing something, or you put a complaint in with the insurance commission and they're like, well, we don't govern those plans. That is why. So understanding that, and then you could actually, guys, take this, you could click on Colorado, and I can go down into every county and I can say how many lives in that county are self-insured. Because in some areas, it could be upwards of 80%. In some areas, it may only be 10%. And most of them would be covered by the state law versus the federal law. And that's why I'm bringing this out there to you, is knowing your data, knowing what I'm negotiating with, how much negotiating power do I actually have if I'm working in there. Now, I didn't drill down in there, but let me just use Denver as an example. Denver, if we drill down into this, it may show it as 80% self-insured. Well, guess what? You're going to have maybe a lot more negotiating power in the city of Denver than Pueblo, Colorado may only have 10%. And if you have governing laws on the books about surprising yet, it may have taken a bit of your negotiating power away. However, if you're the only city in there that does that, and the only 911 entity that does that, then you begin to understand your data. And I'm going to walk you through that to understand, what is my charge master doing relative to the other cities around me. And so just beginning to understand the data is important from that. Here's another piece that most people don't focus on, though we've talked about it rhetorically on a national level, when we all get upset because all of a sudden Wall Street, our individuals are releasing their profit margins. And I remember when United Healthcare, the largest insurer in the nation, released their profit margins, the billions of dollars. The industry again went into an uproar, like, look how many billions of dollars that they are making, and they're giving us pennies on the dollar for our ambulance transport. So when you begin to understand how much gross margin they are making per member per month in the individual market, it starts to open your eyes on something, and it brings this down to the number of insureds. And I find this information very interesting, that right now, what they have looked at, and basically the formulary that Kaiser Family Foundation has done when you look at their state health facts, is they're taking the average gross margin that they made in the state of Colorado minus the actual claim expenditure. So think about it this way: it's they had $1 million in claim payout or claims encounter data. The difference between what they collected in the premium and the actual just direct payout in medical loss is where they're coming up with this average gross margin. Of course, that doesn't extract out anything else. It's what we would typically call the medical loss ratio. And so, not to belabor the point, because I don't want to go too much into it, but insurance carriers have what we call a medical loss ratio. They have to spend so much of the premium dollar that they collect from an insured on direct patient care. All right. In some states, it's 80-20, meaning 80% of the dollars have to be spent on direct patient care. 20% can be used on administration and profit margins and things like that. Some states have an 85-15. There's very, very few that will do anything below 80. Some are a little higher than that, and each different product is different. So Medicaid managed care might be one way, Medicare managed care is another, commercial insurance might be another, but that is all set and codified in federal law or state law. Maybe one day I'll do a whole education on MLR. And I'm bringing that up as well because the healthcare industry has no such thing. And so expect that to continue to percolate, that insurers say, well, wait a minute, we're told how we have to spend our money, and we're mandated that X percentage of our money has to go to direct patient care. How would we look at that if we had the same thing? Think about it like an ambulance loss ratio. Some of us might like that. Some of us may not like that, but just think along the concept. But this $138 is that different that they're saying per member that is within that percentage. So this is outside of the direct patient care. There's $138 per member. So if you're looking at and you're about to contract with an insurance carrier and you notice they cover 1.2 million lives in the state of Colorado and their average margin is $138, well, it doesn't take a rocket scientist. Just add the numbers up and you can see what their average gross margin that they're looking at before they start factoring in all their administrative costs and their profit margin. Hopefully this is making sense. If you got questions, hang tight and we'll answer them. Here are some sources that I'm going to give to you as some source data that I have here. So if you're like a data geek and you're like, man, I'd really love to drill down into this, these are active links. It'll take you directly where you need to go and play at it and have fun and start drilling down into your areas to try to see where things are. But here's some good sources to kind of go to that'll start directing you on what you need to do to kind of gather the why and explore and understand your other party who you're going to be negotiating with. And this is where you're going to start first and do your due diligence. Now, let me tell you, you've done all that. Now, well, I got all my stuff together now. And so I'm going to negotiate with these three payers, or I've got two payers that I really care about right now. And so I'm just kind of eyeing it. I'm really not sure if I'm going into it or not. So there's two different approaches that you can take with contracting. One is I can take the initiative, go on the offense, and start the negotiation process first, okay? There's pros and cons to doing that. Or I can wait for them to come to me. My preferred approach is wait for them to come to you. You're in the better negotiation seat when you are waiting on them in this particular case. But if you're going to go to them, you can still negotiate You just need to make sure that you have done all your due diligence and working through that process. So it just depends on the seat you want to be in. I like to be in the driver's seat, so I'm gonna wait for you to come to me. And to get you to me, I might instill some different practices internally, especially if they're sending money to my patient or they're doing something like that. I'm going to do some aggressive forms by still keeping the beneficiary at bay and being customer service friendly, but get them to the table pretty quickly. So let's talk about it. Number one is it's all about relationships. And this is the area that we have failed as an ambulance industry. As a healthcare industry in general, there's been some really good ones. Hospitals have really gotten on board with this pretty quickly. Either they have bought out and decided to start their own insurance health plan, or they've understood the power of relationships, or they've onboarded and hired people. Unfortunately, we don't have some of that same financial resources that maybe larger systems might have to be able to do some of these things. So where do we get at relationships? We really do great at relationships on the local levels. We even do great relationships on state, depending upon who you are, on the federal level. But a lot of times what we've done is we have failed to keep the relationships and understand the relationships with the insurance carrier. And it's what I always like to talk about. And I love this quote by Pranav that basically says, think of relationships as a bank account and making deposits. You can only withdraw as much as you've deposited. So a lot of times people are like, well, the insurance carrier isn't calling me back, or I've called them and I'm remanded here and I'm doing this here, or what have you. It's really hard to be a hard negotiator and to do things with people that you have they have a friendship with, or you have a relationship with, and I've gone to dinner with you. But it takes time to cultivate and build those relationships. So some of us are starting from the back end. I remember when I was working with the Blues out of the state of Texas, it took me almost 5 years before I went into a contract that was very advantageous, but it took 5 years to cultivate a relationship with the executive leadership team, and that just happened over time. It was through coffees. It was not a relationship, having coffee or having drinks or happy hour or dinner, and then I'm asking for something. It was just a relationship. It was finding commonalities. And so this is not something I want to spend too much time on, because if you have relationships, you are going to be able to negotiate from a position of strength. If you don't have relationships, we're going to have to move to number 2 pretty quickly. And that is talking about rates. So depending upon where you are, I don't care if you're initiating the conversation or you are responding to a request, always don't do anything else before you work through rates. Everything else is just going to be in vain. It's going to be a distraction. I don't care what they tell you. I don't care if they say you got to fill this out. We want to get all this. We want to credential you first. Absolutely not. It's about rates first. And always get them to propose first. So this is usually where if you are in the position where you're the respondee, so they have reached out to you, you are in a position of strength to ask for their rate structure. They came to you, they knocked on your door, they made a phone call to you. Sure, send me your rate structure and we'll kind of start talking from there. If you're the one that's initiating, a lot of times they will want you to propose a rate structure. And so usually what I tell people there is, especially if you're new in this and you're not used to doing it, is play the dumb card. You know what? I'm not really sure where we start. We always start with our bill charge. I mean, if you've got something like that, why don't you just send me something and then I'll take it to where I need to go. Or you get somebody from maybe your billing office, if you're the owner of the company or you're the fire chief or whoever you are, get someone that is mid-level management or low-level management to do the first negotiation side. So that way you can play good cop, bad cop as well. And that is an issue, especially if you're going to go on the offensive and you want to start reaching out. I wouldn't reach out first at the level that is the decision maker. I would send that to someone that maybe I'm going to groom for that. Maybe it's somebody in my accounting office, whatever that is, so they can say, you know what, I'm not really sure. I don't have the, I'm just kind of whatever excuse you want to make, kind of give them a title or whatever, but don't give them the authority to quote rates or anything like that. And so that way there can be this, it opens up another layer that allows you to have a buffer in between. But rates are the really important thing. Don't move forward further in any negotiation on anything until you've done the rate structure. I find it interesting that I'm seeing happen across the United States now, is a lot of people have already gone through the credentialing, they've reviewed contracts, they've agreed to contracts, and now they're waiting on the rates. And I'm like, well, we got this backwards. So what are you going to do now? You've given the inclination to everybody that you've met through good faith, and now you get the rates. You don't like the rates. There's no good faith, and so your area of argument, you're giving away leverage that you don't need to give away right now. Number 3 is data. And this is where we lack as an industry in general. However, because this is first party negotiations happening here, so this is between you and the insurance carrier. It's all about your data right now. We will introduce data from others, but right now it's all about your data. And it's not just about payment data, because remember the data that the insurance carrier is going to be looking at if they want to challenge your rate structure or go into a good faith negotiation with you, which is what they're going to have to be able to prove that they did. And a good faith effort negotiation isn't, here's our rate structure, take it or leave it. That is not a negotiation. It's to go back and say, wait a minute, I'm also doing all of these responses that maybe I'm not billing you for because a transport didn't occur, or I didn't do any treatments, that I'm also doing for your subscribers that we're not getting paid on. This is all factored into the cost of providing the bill to you, not just that I am billing you for 15 AO427s or ALS emergencies, 35 BLS emergencies. And so you're only showing that you have claims encounter data of 75 claims for the year. It could be that you've got 300 responses a year for their members. The problem is the data resides with you, not with them, because you're not even billing it for a zero pay or whatever like that. So those are some things that you need to understand as you negotiate. This is data that works. And sometimes they'll begin to want to pay for you. That's why their Anthem Blue Cross is paying for AO998. That's why you're seeing a lot of others begin to pay for certain treatments. But I'm telling you, think outside of just treatments of actual responses and treating a patient. You should be thinking about actual responses, even though it may not be paid, even though you may come up with a whole different policy and procedure of how we handle those type of transfers. But think, this is data that is relevant to your discussions and your negotiation side of things as well. And then you want to do your internal analysis, which I'm assuming most of you probably have done or in the process of doing, especially if you're thinking about going in network, is I'm looking and seeing, okay, if they give me certain rates, what is that number that is break even for me right now that I'm getting out of network? Does it alleviate any administrative burden? What am I writing off? What are my zero pays associated with this provider that could possibly turn into payments if I went into contract? And what is that number that I'm looking to start from? What is my drop dead number that I can't go below, because I'm not making, I will be losing on the contract versus making any money off of it as well. And so, and all these other additional services that people begin to factor in, they may not be thinking about, you'd be surprised at how interesting some insurance carriers are getting in some of this stuff and many contracts that are being negotiated based upon this, especially in the government emergency world as well, or what have you too. So just know your data. Okay, so we're going to keep talking about data, and you're going to see a general theme here. And there's the reason why I'm talking about data, because once you know your data, you know your negotiation power here. The next thing that I want you to do is really, you should be doing an analysis. You should know what your cost per transport is. Okay, we're not talking about the federal cost data collection process we're coming through. Most individuals should know what their cost per transport is. What I'm finding out, and what we've been finding out over the last few years, and I'm sure Scott has alluded to this if he hasn't talked about it in one of his presentations that he's done already, is that generally speaking, the majority of the industry doesn't really understand their cost. And that's what we're really finding out. I think we're getting there. We're doing much better work getting there. But you really need to understand your cost for transport. Doesn't mean you got to share it with anybody. You just need to understand it, because insurance carriers are wanting to start there. They're wanting to go to cost and then give you something over that. Okay. And in absence of that, they want to go to Medicare and then maybe pay you Medicare or something over that. We as a provider group like to start at our bill charges and go somewhere down. The problem is our bill charges are not built on any methodology. Our charge master is not on any methodology. At one time, consultants were going and traversing the country, whether it was in EMS, whether it was in the emergency physician space, and they were basically saying, you know what, charge 300 times Medicare. That's a good place to start. Or 400 times Medicare. That's a good place to start, and just make sure that your rate is somewhere and round it up and make it at least 400 times or 300 times more. And so that's how bill charges actually started. The insurance carriers know that's what happened, because a lot of consultants were going around and doing that. And it didn't take them a rocket scientist to back into the numbers and look at the Medicare fee schedule, figure out how many times or what multipliers of that to get to a number. That's why you hear 325. That's why you hear 250. That's why you hear 375. And that is because they understood the methodology that's happening here. And so it's disingenuous if we come back and say, well, our cost is for this example, $875, if it isn't that, because then they can start and they'll start factoring and doing your charge master analysis for you. And so that is where we've got to get smarter as an industry and do our own charge master analysis. And so we work through this, and you kind of understand where you're at, and you kind of build it. And this is just giving you an example of how you would do that. You don't have to use this example. I'm just getting your mind thinking on how you're going to go through this if you're going to do this. If what I'm telling you right now and you're like, holy crap, Asbel, that's too complicated to me, I'm just going to take their rate structure, I would strongly suggest that you may think before you do that and lose money, there are individuals that can help you with that. I'm one of them. If somebody doesn't like my personality, that's okay. There are people that can walk you through how to do this, so you're doing the best thing, not just for you and your entity, but also for the industry in general, because this is going to impact how we negotiate contracts, is going to impact us in the future. And a lot of people say, well, wait a minute, Asbel, there's certain things we can't do as association because antitrust, things like that. You're exactly right. It doesn't negate you from looking at certain contractual things or like what's in the contract, but rates and things like that are definitely something that you should not be doing in a association, but you should be working with consultants to try to help you through at least analyzing it. So you're looking at things from data, and the data that's readily available to us out there already. But this just gives you a little bit into understanding it. Okay, you've done all your data. You've done your research. You've gone through this process. Now you are going to start the negotiation. And remember, and I'm using things like good faith effort, because that is something, and that exact nomenclature is being used throughout the No Surprises Act. And it is have to show it. One of the things, and I'm going to review that tomorrow with you, but one of the factors, if you decide to go to arbitration with a provider or something, is they've got to be able to prove that there was what good faith efforts were made by the provider or the payer to enter into a contract agreement. And so if you are reached out to by Aetna to go into contract and you say, nope, I don't go into contract, you're going to pay me whatever I tell you to pay me because it's codified in state, that is not a good faith effort. That's basically saying, too bad, you got to do whatever I tell you to do on the ordinance level. That's no different than the insurer saying, here's your rate structure, take it or leave it. Neither one is a good faith effort. Now, you may not go into and you may not agree to their rates, but you've got to come up with a way that you're going to acknowledge receipt and respond to them and work through a negotiation. Now, the negotiation may not come to something that is a win-win for either one, and you may not even go into network, but you should be able to demonstrate we tried and the other party was unreasonable in their efforts as well. And so that is a part of your negotiation strategy. If you're on the offense and you're trying to get ahead of this and you want to go ahead and start the negotiation and it hasn't been reached out to you, then the same thing would apply to them. If you reached out to them and they said no, then you want to record that. You keep everything in writing, write down all your negotiations, even if it occurs by phone. Then you would always follow up with the carrier on here is what our conversation was about. And if there was any action items left, you need to keep meticulous notes and keep them on file, because this may prove very handy for you in the future, whether you do something on the state side or on the federal side, in case you've got to go through arbitration or mediation. Now, that's the negotiation side. Say, for instance, you got all the way through it. We got a rate structure that I agree with. Okay, I love the rates that they're doing. I've got all that. Now I'm going to get into the contract. And this is where the terms and conditions are. This is the T&C. Most of you got really familiar with terms and conditions in the provider relief round. When we started doing the phase 1 and phase 2 of these funds, they required you to sign the terms and conditions, and based upon the money you received, you were subject to the terms and conditions of that. This is what we're talking about. So it's not just one thing to say, got a rate structure, now I got a contract. So now that I'm going under contract with them, it doesn't matter what state law says. There could be stuff in my contract that will preempt that. Like I could obligate myself to stuff that maybe the state law will not allow for, unless it's strictly prohibited that the insurance carrier cannot do that. This happens a lot, guys, if you go under contract with Medicare Advantage plans, as well as Medicaid plans, that sometimes they might give you the Medicare fee schedule, but they've got some other terms and conditions that might not allow you to do certain things that you may have been able to do for instance, with Medicare fee-for-service or under the Part B side of it, that won't allow you to do it under the Part C side. Same thing with Medicaid. So terms and conditions are important. Here are a few points that I'm going to strongly suggest that you look at when you go through that. Is make sure you don't give away the prudent layperson's definition of an emergency. There are some that I have seen that you've had to strike from the contract because they wanted to make it generally very, very restrictive on what an emergency call is, and may subject to a downgrade to a non-emergency. Also, prior authorizations. If you do non-emergency ambulance transports, this is a very, very common clause within a contract, is requiring a prior authorization on a non-emergency transport. So if you do that, pay very close attention to that and what you agree to. Also, pay attention to disclosures that are required to give to the patient for non-covered services in order to bill their patient. So there are some that say, well, the insurance carrier doesn't cover it, I can bill the patient, and all of a sudden they get a phone call and the insurance carrier said, well, did you notify the patient they were going to get a bill? And you go look at your contract and it basically says you got to be able to prove that you informed the patient in writing that the services was non-covered. A lot of this stuff is in there. It's not meant for ambulance services. A lot of times they're using boiler template from physicians and others that they are using for you. Pay attention to that clause. It's probably the one biggest clause that I see gets ambulance services that go into contract all of the time, and then they're trying to undo it and get out of it. The appeals process is another thing that you should look at. So these are some of the things that I would actually get with your billing department or your billing company to review some of these provisions. If you're operating, if you're a CEO or you're a fire chief, you may not know some of this stuff. They will tell you, well, I'm just going to give you a heads up. If I need to bill, it gives me 60 days to do that, and then I have to write it off or bill a patient. Really understand some of those issues. Your termination clause. What's my termination clause if I don't want to get it? What's it, with cause or without cause? I've seen some contracts, one that was just happened, it was a 9-month termination clause. Like, what in the world did you agree to? Most of them are going to be between 60 to 90. There are some that is with cause only. There's a client that I'm working with up in the Northeast area. The contract that they signed with a major carrier had a with clause only, and then if within 30 days they were able to work through and whatever, they could not get out of that contract. unless it was with cause, and then you had to give the other party 30 days to rectify. That's a crazy contract. And so those are the type of things to pay very close attention to, that if you don't know what you're doing and you don't understand this piece of it, these are things that you should be taking a look at. If you don't have the ability or funding to have an attorney look at it, because that's a lot of times what happens here is people don't want to pay the funding for an attorney to do it. That's why I'm giving you some different provisions to really pay close attention to if you don't have the funds to work through and have an attorney actually review. Your clean claim definition. How quickly should they pay a claim? If I send it in clean, and make sure they do that. And then what is their penalty associated with it? This is common language that will be in there. Some states require it. Many states require this within their insurance code. So that's very similar to what you do. And then coverage limitations. Pay very close attention to coverage limitations. We're seeing more and more of that. And what I mean by that is, okay, I'm going into contract for ambulance, but do you have an emergency? Do you have a coverage for emergency ambulance service? Do you only pay for 10 rides a year? Do you only pay up to $10,000 a year? We're beginning to see a lot of this in air ambulance now, that in order for insurance carriers to get around the No Surprises Act, they're changing the coverage limits, which is very interesting. It's a game, but the No Surprises Act is not a coverage bill. It is a payment bill. And I'll talk a little bit about more of that tomorrow. And we're starting to see a lot of that also in ambulance. We've been seeing that in non-emergency space for ambulance for years, but we are starting to see this happen in some southern states now, where they're capping coverage limits at a certain dollar threshold. That's all they will pay out on a transport. I don't care if it went 350 miles. They will pay a max amount of money per emergency ambulance transport. So these are things that you're going to want to pay attention to, that, yeah, I'm going to go under contract, but does it still benefit me because you're capping my coverage limits? Do I have more resources afforded to me if I stay out of contract than in contract? Maybe I can balance bill the patient. Maybe I can do some type of, I can procure it some other way for the additional amount that the insurance company can't pay for me. So those are the things that you need to kind of factor in once you get to rates, is looking at some of those terms and conditions. Well, I told you I wouldn't take you that long, guys. That is about, in a nutshell, what you need to consider. And I'll kind of stop here. I know we've got, we've got about 10 minutes, it looks like. So I'm going to turn this back over to Kim or whoever, if there's any questions from the group. I will give you this QR code if you want to scan it. You can actually download what I gave to you, as well as Kim can get this emailed out to you. Kim, I don't know if y'all are still there. Somebody's speaking.
We are. Sorry, Asbel. Yeah, we're good. Just looking to see if there's any questions. We've had a few people move online. You can, once you're done with that, if you want to stop sharing.
Okay.
Let's let people get that. Very good. Any questions online? I'm not seeing any hands raised at the moment. How about here in the room? Mr. Dienst?
Asbel, is there any movement nationwide with the insurance groups on community integrated health, community paramedicine? How do you include that in your negotiations with payers?
If you're in that, yeah, if you're already in that space with MIH or CP or whatever, I'm strongly suggesting that you do a bundle. There's some that are doing it and bifurcating out the two. But if you are working and you're seriously consider moving into network, my strong advice right now is, unless you're being approached, don't go into a good faith effort negotiation, unless maybe you're trying to do other ancillary services and your business model is changing. Because wherever I believe or not, these are decisions you need to make. There is insurance carriers negotiating all of it. There's several of us that have been involved in that. We've negotiated stuff successfully through the process. My history has been I'm doing that right now with several different other ambulance services and working with some negotiations on that if they're doing that piece of it. I would strongly suggest you do all of it, especially if you're moving into that. But there is some success that people are having by keeping them bifurcated. It just depends on what you're doing, like that data. Go back and look at your data. If you're in an area where there's a lot of lives that an insurance carrier is trying to work through, it might be one of them are very open to keeping out the ambulance side of it and just focusing specifically on your community paramedic mobile integrated health stuff. Now, if you're wanting to do something differently for another that may not have as many lives, or they don't have as many comorbidities that they're trying to do, you might have to look at maybe negotiating everything within the package as well. So as you can hear from my response, it's really going to get down to the carrier, to the number of lives that are being covered, and what they're trying to do through that process.
Yeah, I believe somebody just took a picture of the QR code, and it's EMS Fire, the No Surprises Act 22 and beyond.
Uh-oh, it's pointing to the wrong one. Don't pay attention, that's the one tomorrow. Sorry guys, you guys are going to get that. They must have put the link to the wrong one, but I think if you scroll down, it's probably going to lead, it usually leads you to the same one. I'll be getting with my person right after this. That's a no.
Oh, Susanna, man, you're going to be on her now, aren't you? Other questions in the room? Nothing? Okay.
So wait a minute, because I have something I want to propose. Since there's no questions online and there's no questions in the room, there's something I want to propose to you just for your input as it relates to figuring out ambulance rates. Are you willing to look at it and potentially criticize it, figure out what's right, what could be wrong with it?
Sure. Yeah, if you send it to me, I'll be more than happy to give you an opinion on it.
Okay. I mean, how much time do we have?
We've got 30 minutes.
So we have 30 minutes. So can you promote me to panelists?
Yeah, they're 90-minute sessions, Asbel.
They're how many? Oh, they're how long are they? Oh, you know what I do? I ended early. Look at that. Good. Okay, well, we can talk about it or however you want to do.
Okay, Tim's going to pop up something on the screen for you to look at, and hopefully it'll be valuable for everyone.
Yeah, I think it would be. So, Asbel, I have been trying to figure out how can you come up with a way to come up with a more transparent means of determining what you're charging patients on ambulance bills, and something that you can justify to even patients when they call up to complain and say you're charging too much. So this is what I came up with. So you obviously have your costs, right? There's two costs to consider: the cost of running the service and the cost of uncompensated care, right? How much of the contractual bad debt and so much is written off. So in my example, what I'm saying is we have about, let's see if I can make it larger so everybody can see it a little bit better maybe. Okay, so let's just assume that your operational costs, your budgeted costs are $5.6 million. Okay? And your estimated transports is going to be right around $1,665. So that gives you an average cost per transport of $3,374 and some change.
And that's based upon, yeah, but let me ask you the caveats around that. This is the specific appropriation for everything inclusive within your department. It doesn't matter what it's for, so it includes everything.
Right. So I'm trying to get to the full cost of providing ambulance services. Okay,
And you do know that for some, there's permissible cost, impermissible cost for others, and we get into that piece of it. So I'm just going to I'm giving you that caveat for a reason. So when you start to move into this, you'll need to understand those dynamics, but go ahead.
okay, so there you have what the average cost for transport is $3,374.08. Well, I'm a public entity, right? So in theory, some of that cost is prepaid through my property and sales tax. So what I do is I take a look at, so what is coming in regarding my property tax, my specific ownership tax, and my sales tax, and I see that that's $2,703,000 and some change, right?
Mhm.
So I also have some other prepaid costs, such as grants, the SRP, the Supplemental Reimbursement Program, and my contract revenue, especially on my behavioral health side. So that's an additional $1.2 million of revenue that's prepaid, right? So then I take all that revenue, taxes and the other prepaid revenue, and it's like $3,900,000. So now what I want to do is try to figure out how much of the prepaid revenue is there. So I take that revenue number and divide that by my transports. And I come up with $2,377.90 is prepaid. So then what I do is I take my cost per transport, right, from my original calculation. I subtract what is prepaid, and I come up now with what I'm termed as a modified cost for transport is now $996.18. So I know no matter what I do, if I'm negotiating with a patient, like what is the minimum I have to bring in at least to cover some of those uncompensated costs? Well, that tells me that I need at least $996. At the beginning part of the conversation, we said there are two costs, right? And this is supported in the AAA documentation as well. There are the direct costs of providing ambulance services, and then there's the uncompensated cost of care, and you determine that by your collection percentage. My current collection percentage is 35%. Now, using the AAA computation is even with my $996, I'm not going to get that from 72% of my payers, because 72% of my payer mix is Medicare, Medicaid, and the private payers or the uninsured. So I use my cost of uncompensated care, the collection percentage of 35%. So I take that $996.18, divide that by my collection percentage of 35%. And what that tells me then is my average ambulance bill going out the door to cover my expenses and my cost of uncompensated care has to be right around $2,846.23. Now I can figure out what are my base rates based on that and my mileage charges, but my average ambulance bill has to be $2,846.23. All right, shoot, because this is ambulance funding and finance, excuse me, according to Tim. Doesn't necessarily mean it's valid, it's reliable, or anything like that. But when somebody's coming up to me and saying, why did you charge so much for that ambulance service? At least I can show them a methodology, a way that I don't think this is like colluding as far as, what is it, the term that they use? It's not colluding, it's price fixing, because it's based on our cost, our transport volume, our revenue sources. It's a system, it's a methodology, it's a formula. All right, so now I'll shut up and say what's right, what's wrong with it.
So I will tell you, first of all, the methodology makes sense till you get to the current collection percentage. So here is the issues that we're going to have as an industry. What defines cost? So your appropriations is something that your local community has said, we're okay with this appropriation. And this is the same analogy that I always use. Can a Ford Focus take you from point A to point B the same way that Maserati will? Yeah, they can both get you there. One's just much more expensive than the other. And who's going to absorb that cost? Is it going to be the insurance carrier? Is it going to be Medicare? Is it going to be Medicaid? Or is it going to be the community that decided they wanted a Maserati over a Ford Focus? That is the dynamic of the issue that we're going to have here when we start talking about cost versus reimbursement. And then you get down into, well, I'm collecting 35%. Okay, well, then I want to go in there and audit your collection practices. Because is it 35%? What, maybe you should be getting 40. Maybe you've got bad collection practices. So your methodology makes sense. Like, I'm not disputing what you're going through to come up with your number. But on the other end, if I'm playing devil's advocate with you, that's where I'm going right away at the very beginning, because that is what I'm anticipating is going to be our debate and argument when we start getting around cost. Is at what time, and I've had this debate already with the health plans, I actually sat on a panel debating the same exact thing, is why should we pay that one city wants this and the neighboring city 30 minutes away has a whole different system, still gets them, but it's costing 2 times more. It's the same issue that hospitals are having, that a mile down the road, the person that's doing the cardiac cath is $50,000 more than the one that's a mile away. What is the fair rate to pay? What's the reasonable rate to pay? And that's where the median number starts to come in. This is where it gets complicated fast. And so that's why I'm saying, while you're looking at this, the dialogue should be much more around what is the reasonable way to get a patient transported, regardless of the community that they're in. Now, we don't like to have that discussion, because nobody wants to be told that in my community, we want it this way, and in another community, they want it another way. And we're not looking at, okay, how can we safely get a patient, if they require to go by an ambulance, transported? There's a whole argument that Matt and others have been out there talking. A lot of us have been talking around the other mobile meds. Should they even go beforehand? But let's just talk about the issue. They need to go by an ambulance. How does that look? And so we start then talking about, should it look like a utility model? That's what we're talking about. We've always been a third service. So your methodology isn't wrong with what you're doing. You guys need to be anticipating, what are the arguments that are going to come from the payers? Medicare, Medicaid, the others that are making up your 35%. Who is making up that gap? Right now, from what I'm looking here, what's making up about 50% of the gap right now is all of your property taxes, and then you're going into your grants. It's over that. So there's a lot of funding that is not even a part of the reimbursement model that is looking at that. So that gap that you've got right now in your current construct of cost based upon your appropriations is that $996. And you are trying to use that through your current collection percentage, which that's going to be debatable, of saying, okay, if I'm going to use that, am I open for somebody to come in and now I'm going to audit? So let's say the IRS agent's going to come in and they're going to audit it and say, you know what, we think you could get 48% out of here. Or we move more to universal healthcare coverage, where everybody gets a rate, so everything that you do is paid for. And then you work within those confines and then supplant it if your local entity wants more, then they pay for it, like a utility bill or water or electric or whatever else it is. So you're going to pay a certain fee based upon usage. Everybody gets that. So is that what we're going to be talking about down the road as we start talking about some of these pieces as we start moving through the mix? I don't know. But I will tell you in the next few years, we're going to look a little different in some of our models, whether it's in rural, super rural, because it's going to basically start back to access to care. Do they have access? Is it going to be through more of the expansions of the community access hospitals? Maybe more of our ambulances are going to be tied to CAHs or to these new RECs, which is these regional, these rural emergency clinics that are standing up now. So are we going to have something with that's going to look a little bit like that with oversight of the rural EMS agencies? I don't know if it's going to be paid for by a Medicare Medicaid component. Are they going to carve government totally out altogether and say, let that be a state tax-based issue and we'll send the money directly to the taxing entity? And in the more large urban entities, we're going to look at something differently for emergency versus non-emergency. I'm not sure. All I know is when we start talking through things like this, we open up for a lot of conversation to begin happening as we talk about cost, and that is going to come out as we do data collection. Hopefully it'll come back and we have more aggregate data over the next 3 to 4 years. But just looking at what you're giving me here, working through to try to come to something, I'm going to dig holes in it if I'm on the insurance side. If I'm on the state side, I'm going to make it all about local. Like is for your service, is that really the number? Is that cost really the number? Or should we have an auditor come in and really look and see, you know what? Instead of replacing your vehicles every 3 years, why don't we move that out to every 5 years? Then we can do this. Do you really need this infrastructure resource here to get the patient from point A to point B? You start opening that up when you start talking through this. And that is what's been happening with hospitals for years. Home health, all of those is where's the pain point that we can keep crushing the rates to make people make sure that there's not a lot of waste in it. Because we have seen that in our industry. We have seen that in the hospitals have seen that. The physicians have seen the waste. The public health emergency showed the waste really fast. Showed we didn't even understand our materials management side of things. We didn't even understand our just-in-time processes of material management. I mean, it exposed a lot of inefficiencies that were within the healthcare industry as well, and that maybe there was some inappropriate costs. Wrong, right, or indifferent, it's happening, and now we're grappling with that. I don't know if that was a long-term. You did ask me for my opinion, so I'm giving it to you.
Perfect. I mean, that's what I wanted. I wanted to know what was right. And so it sounds like the biggest thing that we have to figure out is what are we determining as our costs? How are we determining that? And of course, that's gonna vary from one agency to another. Because I can tell you, even when you're thinking about replacing ambulances, I just recently put on death row my 2002s, type 1. So got a lot of great life out of it, but
and it gets down to the community.
I pay my salaries, my insurance, my utilities, my fuel bill, my medical supply bill, all that stuff. That's what it costs.
It is reality when you get down to that. And that's where the industry has to look at. That's where policymakers are going, insurance are going, and then local governments are going because of property taxes and tax. And so then your communities get involved and say, do we really need it to look like this? And so we've got to be prepared as an industry for more scrutiny. And we haven't wanted a lot of scrutiny that says, okay, well, wait a minute. Do we really need to have 2 paramedics on every truck? Do we have data that shows there's a quality issue based upon that? I mean, I know we've been working on that, thinking through that concept. Do we need on basic calls? Do we need to have 2 clinicians on every one, or could we have something else? We've been playing around with models like that. Those are the type of things that we need to be prepared for as we start screaming, pay us our cost. Is the element of scrutiny that then becomes to get with that when you start having a cost argument. That's why the insurance carriers want to have the cost argument, because guess what that means? Much more transparency. Why does the healthcare community want to have more of a bill charge downward? Because it doesn't require as much transparency. So when you start having a cost argument, it's a lot more transparent, a lot more looking under the hood. I'm not saying it's wrong or right. I'm just saying the different perspectives of why we're doing why the dialogue is playing out like it is playing out right now.
Asbel and Tim, it's Sean Caffrey, Asbel, and I don't mind, I just like to pick on Tim a little bit and let both of you react to it.
Just pick on him.
No, because it was your numbers, man.
Right.
A couple things that jumped out at me, Asbel, I'd love you guys to react to. So the first thing Tim did was work off revenue base, or essentially that side, the income side of the ledger. And I'm a little curious. I know our Medicaid supplemental reimbursement program here in the state completely ignores the income side of the ledger. And almost immediately looking at Tim's spreadsheet, he's kind of saying, and we're not going to put anybody else on the hook for all this prepaid tax money coming in, although that's a reasonable expense. And so I'd love just some commentary on that. And the other piece, since you worked off your income side, you completely lost your depreciation on your capital assets, because your budget coming in for this year isn't catching any of your depreciation.
It is in my financials, so depreciation is part of it, yes.
But you're working off your income base, are you not? So instead of all of your assets depreciating a little bit every year, you're only throwing in the mix the assets you're buying. Well, in this case, probably last year, right?
So this is what was anticipated for this year, yes.
Right, and that just, I think my only point there is it might miss the entire scope of all your capital assets, because it's only dealing with the stuff that you're replacing right now.
Right.
So anyway, I'll
So
stop
I
there.
mean, but that is something else to consider. I mean, I put this up here to get reactions just like that from Asbel, and I see Matt Zvatsky's on now, and from everybody in the room too. What's right, what's wrong, and even when I'm trying to come up with something that at least in theory is defendable of what we're charging, as opposed to what are you charging for an ambulance service? Oh, well, this is what I'm charging. Oh, okay. What are you charging? What are you charging? To me, that's more destructive for us as an industry, because we're not basing it on anything other than what everybody else is charging. And at least this is based on something that could need some fine tuning.
So what you're doing here, Tim, is, and this is because the charge data is out there, it's becoming more and more transparent through the process. So there's a lot of transparency files that a lot of us are going through, and we are beginning to actually able to see pretty granularly now where different NPI numbers are where the different NPI numbers are relative to the different charges by the base codes and what you're sending over. I mean, we can get down to that pretty granularly now. So it's not like you're hiding something by saying, I don't want to tell people what I charge. That train has left that station, and it is going to become even more and more transparent over the next 12 months. I'm not worried about that anymore. What is not transparent is cost. And your appropriations is what you led off in your spreadsheet. And this is, Sean, to that point, because I'm not looking at the appropriations as a revenue. And this is the only reason why I'm saying that is I'm going off of what you said, Tim, that if you're going back to your governmental entity and you're saying the cost of running my service is the amount I'm asking for the appropriations. Is that what I heard you say?
Yes, essentially.
So you are going to them saying to run this service for my district as a governmental entity, I need you to appropriate $5.6 million. That's my cost. Because you don't typically put profit margins when you're doing it. Now, you might put some stuff that I need capital. I've got a budget. I need to do some things as well. But I'm taking this from the governmental lens. Then you're backing into it and saying, okay, then I want to kind of take out some of the stuff that I get from property taxes and things like that we are trying to say are supplanting some of the cost. And then after I do all that, I think direct payers should then pay for everything else. I'm just surmising here. I don't want to put words in your mouth, but I'm just following your logic. Whether I agree with it or not, it's a different story. I'm just following the logic. I've got an appropriation for my cost. My government entity has approved 5.6 million. But now I get property taxes for this, contract money for this, some other grants that I'm doing for this, yada yada. And then I get to my 2 point, whatever, my 3 point total prepaid transport revenue is 3.9 million. And so I'm saying I'm offsetting the taxes and all of the other stuff that the city is doing for my appropriation. So I need additional monies to come in from some other source, and I'm going to go after the third parties. And right now, I'm getting 35% from the third parties of what I bill because of uncompensated care, whatever else it is. And so somebody needs to make up the difference.
The interesting thing, though, is that 35% in theory should change over time. I mean, if we're successful with our Medicare cost reporting and Medicare says, "Ooh, wow, it's costing more, readiness and transport costs is costing more than what we thought," and they increase the Medicare allowable rates, then that 35% changes. So yes, I understand that that may or may not be that 70% of who I'm going to be sending that $2,800 ambulance bill won't come close to paying it. And that you're right, it's the commercial insurance companies that I'm sending that bill to. Somehow the costs have to be paid or we don't provide service.
So who is making up the $996.18?
So my average reimbursement from my commercial payers right now is right around $1,200. So that is getting made up right now. But it's you know, when you're talking about fuel costs rising, our personnel shortages, where we're now starting to compete with each other, and even in this room, on how we're going to fill those seats in the front of the ambulance. And I even understand with Matt's presentation earlier in the day that we may have to think about other models. Like, do we offer just ALS ambulances, or do we have a combination of ALS and BLS? And then do we also put in community integrated health, which costs me a whole lot less? I mean, to me, this 2,800 shows that the ambulance business in general, especially in a more rural environment, is not economically sustainable. So we have to move to something different, something that costs less, but still takes care of patients as best as possible.
Yeah, I will tell you what you're going to be moving to. I will almost bet dollars for donuts on this. Rural is going to go to some cost plus methodology. They're either going to be tied through a hospital system to do that. They're going to go into some other methodology that is not going to be tied on, I'm going to send a fee-for-service bill somewhere. So they're going to go through something like that, unless they push a lot of, which is the plan of CMS right now, which is pretty aggressive, but they're moving there rapidly. You can tell they want to move almost every Medicare beneficiary into an ACO or a Part C plan, which you see that happening quickly. Their goal is 2030. From my conversations with SSIO, I don't think that's going to happen. I think that's a lofty goal. But even if they get 85% done in the next 7 years, or 90% of fee-for-service into MCOs, you're going to be dealing a lot with managed care, and then managed care will look at different models that might be unique, and they may fund everything through a hospital system, or it might be critical access that looks at, or these REC models. A lot of us are watching very closely. That is one of their areas. That was Grassley's brainchild of trying to deal with the rural issues of giving communities in very rural areas emergency access. And when they shut down, or they don't have 24/7, is it hospitals working? There are several that you're beginning to see, even within our own industry, that is really advocating a bit more for the CAH ambulance models, which moves it to a cost plus basis, which that is a level of reporting, level of accountability. There's impermissible cost and permissible cost. That's why I brought that up at the very beginning, Tim. That will tease out in your appropriation what's permissible, what's impermissible. So not all your costs will be permissible, but they'll pay you cost plus one of that. So those are different things that you should be really thinking in rural communities, because I can guarantee you to do access. That is the only way to sustain. They're not going to be able to continue to pay thousands and thousands and thousands of dollars for some entities that may do one Medicare transport or one Blue Cross transport every 7 days. You know what I'm saying? So and that's where it's going to have to be modified to catch that, and especially into the uncompensated care. That's me kind of just looking in what I think is going to happen. I'm sure you've got others that thinks that what they think is going to happen. But pay attention to what CMMI is doing, some of the innovation that they're beginning to do for areas where there's parity issues, and they need health equity, and in rural. So rural definitely is going to be addressed. How is it going to be addressed? I find it very interesting with the introduction of the rural emergency clinics. You will give you an insight into how they are possibly thinking of addressing rural. So CAHs, CMS doesn't, a lot of the not bureaucrats, but a lot of the long-term employees within CMS don't like the cost plus, because it's open for a lot of waste and abuse. The RAC model is very interesting to me because it is not a cost plus, but it does provide for a subsidy kind of component, depending upon how many patients or beds you have. So that's going to be very interesting to watch. But this gives you insight into possibly how ambulance in rural areas could possibly looked at to hit some of the pain points that you're talking about, Tim. Now, that is not urban or even suburban, but think about it from a rural perspective like you're talking about.
Okay, thanks, Asbel, because I see we're coming up on our time. But,
We are close to the end here. Does anybody have any additional questions for Asbel?
I just put it out there to think about. That's it.
See no hands up online, so we will go ahead and let you go, Asbel. We'll see you back here at 3:15 our time.
All righty. See you guys. Have a good one.
Thank you much.